Good evening, everybody. Dear colleagues, welcome to this live webinar. I'm Dr. Hani Mahmoud from Aswan, Egypt. I'm working as an associate consultant, adult cardiology, and director of ECOLab at Aswan Heart Center Mirza Yaqub Foundation. Today's webinar will be focusing on how to use the TOE for interventional procedures, steps, and tricks. I have the pleasure to conduct this live session with Dr. Ralph Stephen von Barthollipen from Heart Center Cardiology, University of Medicine in Mainz, Germany. During this interactive webinar, we'll be dealing with the role of TOE in different kinds of structural interventions, such as mitral clip, TAVI, deflated appendage closure, and so on. The aim of this webinar is to update you regarding the utility of the 2D and 3D TOE in various types of structural interventions, showing the incremental value in some points for the 3D over the 2D TOE, and giving some practical tips on how to acquire and display the necessary 3D volumes, and answering some of your questions according to the time regarding this modality. The format of this webinar includes multiple MCQs that will be submitted during the presentation. Please take this opportunity to test your knowledge. Your vote is totally anonymous. During the 60-minute session, you can also send your questions using the Q&A section. Dr. Ralph Stephen von Barthollipen and myself will address your questions during the webinar. Time is up now, so Dr. Ralph Stephen, please go ahead.
Thank you very much, Hani, for the nice introduction. And I would like to start with the TE for interventions in the mitral space. As already mentioned, I'm an adult interventional cardiologist and head of the ECOLab at our institution. I'm also president of the working group echocardiography for the German Society of Cardiology. These are my disclosures. So interventional echocardiography in mitral procedures first has to start with an echo analysis of patient suitability selection. So we will have a basic 2D or 3D TOE and TTE to assess mitral valve morphology and the hemodynamic consequences of the disease. TOE is also in use for the procedural access and the transeptal puncture, as we will see in these interventions, and also in the special section given by Dr. Hani Mahmoud later in this talk. We have to select the correct devices, have procedural guidance, the evaluation of possible complications, and of course, the evaluation of the interventional success. As you all may know, the mitral valve apparatus is quite complicated. It's not a vascular structure, it's a structure between two heart chambers, the left atrium and the left ventricle, and it's influenced not only by the valvular tissue itself with the annulus and leaflets, but also by the commissure possible clefts, the chordal apparatus, the papillary muscle interaction with the left ventricle, and the size of the two chambers themselves. We have to differentiate when we treat mitral valve regurgitation that we have two distinct subtypes. First, named in our three different publications of the European Society of Cardiology and the European Association of Cardiovascular Imaging as being now primary MR. This is the former term for degenerative disease, which is a disease of the mitral apparatus, known as fibroelastic deficiency, grade 1 to 3, or grade 4 as a Barlow's disease with a bileaflet prolapse. And then on the other hand, we have the functional ischemic disease, now called secondary MR, which basically is a disease of the left ventricle, sometimes the left atrium, with a secondary MV closure impairment, but normally with normal morphology of the leaflets themselves. We have to respect the Chordae Tendinae, which are very important for the different interventional therapies. They are classified by the insertion site, and we also have primary chordae at the leaflet tips, intermediate chordae or secondary chordae in the middle of the leaflet, and the basal chordae cannot be readily seen by echocardiography. They are next to the annulus. So if all three chords are elongated, we see a total valve prolapse, including to the ring tissue. This is a spectrum of mitral regurgitation summarized very nicely by Paul Grayburn from Dallas, Texas. And you can see that on the left-hand side we have functional disease, which can be caused by LV dysfunction, dilated annulus, or by LA dysfunction and dilated annulus due to chronic atrial fibrillation or hypertension. This is a disease that is under-recognized in the guidelines. And on the right-hand side, the true valvular disease, which is a degenerative or primary mitral regurgitation in Barlow's disease or fibroelastic deficiency. This is just a shortcut to the echocardiographic criteria given in the guidelines of the valvular heart disease in 2012, and also in the EAE or EACVI recommendations by Patricio Lancelotti, published in the European Journal of Echocardiography in 2010. There are two distinct situations where we have to use TOE or also biplane or three-dimensional analysis. And one of the typical pitfalls in functional disease is that we have a so-called crescent shape of the regurgitant jet. As you can see here on the left-hand side, in a three-chamber view, we only see a very small vena contracta. But if we look on the short axis, we see that we're underestimating the size of the jet because in the intercommissural area, there's a large curtain of the jet. So both views have to be integrated. And this can nicely be done by three-dimensional echocardiography, as shown here, in a rather round shape of this regurgitation. And you see a short axis and a long axis view at the same time, and a three-dimensional analysis of both the vena contracta and the Pisa zone. This can then be integrated into a three-dimensional automatic analysis in modern scanners. You see that these are images from 2014 from MINDS, and you get an automatic depiction of the EROA, which is in this case 0.42, which is severe in all guidelines and for both functional and degenerative disease. Also in the latest guidelines by Zogby, published in April 2017 from the American Society of Echocardiography. Of course, mitral regurgitation is not a static state, it's a dynamic state. So we have a change in the Pisa size in both functional and also degenerative disease. And in the future, we will see that we will have to integrate actually flow over time, also for the regurgitant flow, as the scanners get a more and more high temporal resolution. Another very important thing is to calculate the laminar floor area and to respect multiple orifices. This is extremely important if we go into mitral clip therapy, where we have as a residual effect also a double orifice. And there's a very nice publication on the role of the edge-to-edge technique mathematically on the regurgitant flow by Francesco Maisano, the director of heart surgery at the Zurich University Hospital, published in JACC 2011. There are easy cases for mitral valve interventions, which is the upper row. As you can nicely see, it's a small prolapse, a chordal rupture, a small prolapse not elevating very high and only encompassing about 20% of the circumference. At the lower part, you see a large prolapse encompassing the whole P2 segment. So this is more than 60% of the commissure, and the elevation of the prolapse is higher. So the first case is easy to treat with 1 or 2 clips. The second case has to be treated with 3 clips interventionally. There are also exclusions to percutaneous therapy in mitral regurgitation, and one of which is extensive mitral annular calcification, so-called MAC. And this is an extreme example just to show you both in 3D TOE and on the right-hand side in fluoroscopy that this, or CT, that these are severe calcifications. So interventional TOE echocardiography is a key step in mitral clip. As you can see, we can have a simultaneous view on a 3-dimensional image down there. You see a large indentation here in the posterior leaflet. You nicely see the distribution of the color in the 3D intercommissural view, taking a biplane view here, and here you see a long axis view giving you the second plane of the hemodynamic impairment And I always like to compare these two levels in black and white to see morphology, and in color flow to see the hemodynamic effects of the different leaflet motions. This is an example of ischemic disease. It is very typical on the left-hand side that we see an eccentric elongation and separation of the two leaflets. You see that nicely in the central part of the leaflet to the left-hand side, which is the medial occipital part. This is an inverse cardiosurgic view. So the posterior leaflet is above, the segment 2, the segment 3 is on the left-hand side, and segment 1, which is smaller in this case, is on the right-hand side. And you see that the separation is at the range of the posterior medial papillary muscle. So this is a typical case in the circumflex impairment, and you can nicely see also coronary sinuses, etc., on the right with modern scanners. The case of the regurgitation in this patient, and you can nicely see that we have a severe regurgitation due to this leaflet gap in this patient due to ischemic disease. So the screening part is now over. So MitraClip edge-to-edge technique requires optimal real-time visualization. You've seen that we have complex 3D spatial structures of the mitral valve. There's an interaction of the device with heart structure that we'll see in the upcoming slides. There's a complementarity of 2D and real-time 3D TE. So in some cases, we want to have very high resolutions. We restrict ourselves to two-dimensional echo, and sometimes we want to see the extent of the disease, where we use the two different forms of three-dimensional echo, which is X-plane, biplane, or triplane imaging, depending on the vendor, and full volume 3D TE. There's a superior guidance of some interventional steps using real-time three-dimensional echo. Here are some suggestions for reading by Faletra, by Binier and Altjok from Aachen, Germany, on these different issues. So what is key in MitraClip? It's first of all the quality of imaging. So two-dimensional and three-dimensional echocardiography, especially TOE, require a very good image in order to perform this procedure fast on, and communication between interventionalist and the echocardiographer is key. We have a conventional orientation of images and a limited number of standard echo views. And this is given to the right-hand side. So interventional TOE can correct different angulations of the valves that you treat. This is important in mitral disease. It will be even more important in the upcoming tricuspid disease. We now come to the procedure itself. So the interventional steps are the transeptal puncture, the introduction of the transeptal sheath and the clip delivery system into the LA, the navigation of the mitral valve and the positioning of the MitraClip into this area, rotation to achieve perpendicularity to the valve, grasping of the leaflets, assessment of leaflet insertion, assessment of result in MitraClip release, final result and evaluation of need for additional clips, detection of complications. The adequate transeptal puncture is a key step in the MitraClip procedure. It's very important to puncture posterior and superior to come high enough and to be above the commissure. And the height to the mitral clip, to the mitral valve, has to be 3.5 to 4.5 centimeters in the forward chamber view. We will see this in a second. So this is a depiction of the MitraClip itself. We have a clip arm which has a length of about 8 millimeters here, where you put the leaflet in, and then the gripper plate is positioned down to the leaflets, where you catch the leaflets between the gripper plate and the clip arm. You then close the clip arm itself. This is how it looks like. It's a copy of the surgical Alfieri technique, and you see that we have an overgrowth of endocardium and tissue over the Gore-Tex PTFE material of the MitraClip itself. This is covered by textile. There is a German guideline published in Clinical Research in Cardiology in 2013, 2014, an English version also, where we have optimally suited patients, where it's easy to perform the procedure. We have a column here of limited suitable patients where more experienced centers should address this patient. And there are certain inappropriate cases like cleft, severe calcification, and mitral stenosis, because every leaflet-to-leaflet therapy will further close the valve, and the posterior leaflet especially has to have a minimum length of about 8 millimeters in order to perform this procedure. So we're coming to the first multiple choice question. Which do you think is the role of imaging, before we come to the slides there, in mitral clip intervention? Mitral clipping for regurgitation involves only fluoroscopy, is best performed classically like in 2009 with 2D TTE alone. It should integrate fluoroscopy and TE, preferably 3D. It is all too complex to be visualized, or, and I hope this is not the case, it does not interest you at all. Please vote. Annie, you will take the vote?
Yeah. I'm waiting for the remaining time, about 16 minutes, 16 seconds remaining for the vote.
Okay. So, Annie, I know that you're an expert on balloon valvuloplasty in Egypt, and do you perform also percutaneous mitral valve repair for regurgitation in Egypt?
Yeah, in some hospitals we can, for those patients who can afford that, because the government is not covering that. So in some hospitals we are doing mitral clipping, actually. And in my previous hospital in Saudi Arabia, we are doing a lot of mitral clips and percutaneous mitral annuloplasty as well. Okay. So now the vote's coming about 95% went for should integrate fluoroscopy and TEE, preferably 3D.
That's perfect. So everybody is online and awake. This was the first important test question. There are some more classical operators too. So we had 3% that want to do it with 2D alone, and also with TTE, which is a little bit tougher task. And I will now explain why this is the case. And of course, if we have an all-fuzz view over the situation, we see that the intercommissural view typically is depicted in 60 degrees, and that we have a 3-chamber view in 150 degrees. The leaflets are normally slightly asymmetric, but you see that the anterior surface has a larger area. And in order to see these different anatomic specifications, you of course can take two-dimensional images, as are the cup planes here. But in order to align the correct views to your two-dimensional views, you have to know the correct angulations in each of the specific patients. And this is very important and can easily be done and deducted from three-dimensional images. And this is given here, as you see. This is one of our early patients in mitral clipping. You see here, this is 2010 already, where we have a mitral clip orientated to the aorta. It's slightly misorientated counterclockwise, and you nicely see here the left atrial appendage that we will see further on in one of your slides too. You see that we have P1 segment on the left-hand side near the LAA, P2 and then P3 in a cardiology cardiac surgery view. This is the modern possibility with 16 volumes per second in order to depict the mitral valve and the different phases of the regurgitation. We get 2D and also 3D information at the same time. We can do this en face from the atrial side and also from the ventricular side, which is a quite modern aspect of valve analysis. And we can also do this in black and white. And you see nicely again here that we have a calcification underneath this area of segment P3, which can also be seen here from the left ventricular view. And the left ventricular view is something that we exclusively have as cardiologists. So imaging should be focused on etiology and pathology. We have very nice soft tissue visualization, and it should be real time. So we continue. The mitral clip procedure is a venous procedure with a transeptal puncture, which is echo-guided, and 3D, of course, is preferred. These are the basic planes that we need in order to really get to the right point to perform the puncture, and typically the puncture is in this area of the fossa ovalis. You see that we have three 2D views of TOE, which is a bicable view, 100 to 110 degrees, the short axis view, which is the 45 to 60 degree view, and the four-chamber view, which can be either a 0-degree view or a 170-degree view. And what we get are these images. You see a 100-degree view where we have the superior cava here, the inferior cava here, and we can draw back the needle, and if we pull the needle, we move to the left-hand side to the inferior cava. We can also rotate the needle. If we rotate the needle counterclockwise, we move anterior. If we move the needle clockwise, we rotate posterior. And we then determine the puncture height, which should be around 4 centimeters above the mitral valve in order to ease the procedure. This is summarized in the slide for you. So all the different views, four-chamber view, bicable view, where we save the superior, and short axis view, where we should gain a distance to the aorta. So it's easier to perform this procedure if we are in the posterior half of the fossa ovalis, because we are more across the commissure of the mitral valve. This slide summarizes all the steps that we will now see. So we did the transeptal puncture here. This is the view of the mitral valve intercommissural and long axis. We see the wire into the left pulmonary vein, the depiction with the correct angulation of the mitral valve, here intercommissural and long axis, the clip getting into the left atrium, bending of the clip down to the valve, orientation of the rotation, and then doing the grasping. These movements allow different movements. So if we push in the system, we come lateral. If we bend the system, we come medial. And also we can pull out the system to come medial. And anterior, posterior is like with the transeptal needle, a rotating movement of the clip system. And we can also use modern fusion imaging actually to guide us down to the mitral valve. You see we use 3D. We depict where the mitral valve is. And this is the circle that we see here, and you simply bend down the mitral clip down to the circle, and you need no contrast agents in this procedure. This is what we would see if we would use fluoro alone, no stiff tissue information, and this is what we see if we use both fluoro and the echo, and you can see that we need to align to the morphology of the mitral valve. So the typical intercommissural view will be 55 to 60 degrees, but we can also rotate to the medial side with lower numbers of angulation, and higher number of angulation will rotate us here to the lateral side. This is a misaligned clip, so we see nicely that we should address actually the aortic root down here. You see the aortic root down here. You see that the clip is now nicely aligned from 12 o'clock to 6 o'clock, not disturbing the valve, which is also summarized here. And we can do these images simultaneously with 2D images at the same time with modern scanners. A second very modern approach that you will see more and more is the possibility, like in CT or MRI, to do multiplanar reconstructions or flexi-slice while doing echo, and you can rotate your laser lines anatomically through the valve without caring for the 2D views. And you see we nicely align the clip. We see the clip arms just by aligning these laser lines through the clip system. We can look on the clip getting through the valve from the left atrium, and we see the clip here through the leaflets from the left ventricle, and can nicely align this. You see the regurgitation before the treatment in 3D, and we can then use a high resolution grasping of the leaflets. Leaflets lie on the clip. We catch the clip by pushing the grippers down, the gripper plate down, and the clip will then secure the connection between anterior and posterior leaflet, and the mitral regurgitation, as you see on the right-hand side, is almost gone. And this is then checked in three-dimensional echo to secure the analysis. Mitral clip does not always mean dual orifice. We can also have a single orifice. This is a prolapse patient that we have here, and you can nicely see it's a huge prolapse in this patient that we have here of the posterior leaflet, and we clip this like a Wooler technique in surgery, and the result, as you can see here, is a very nice single orifice with 2 clips here, and this is like a surgical suture. This patient has no regurgitation whatsoever and also no stenosis. To assess the mitral valve area pre and post clip, you can use 3-dimensional echo, as you see here in this multiplanar analysis, an en-face view in 3D echo using 3D quantification software like QLab or the echo software by GE or Siemens. And you can nicely see that we can differentiate the orifices and also the residual, very small 1 millimeter residual jets in this patient, or doing 3D PISA. So this concludes the first part with just mitral clip conclusion. We have seen that TOE is very important in mitral regurgitation treatment, 44,000 procedures worldwide, 25,000 in Europe now altogether. The indications are degenerative or functional disease at increased or prohibitive risk for surgery. We need a heart valve decision. Key is 3-dimensional echo, temporal and spatial resolution as well as image quality is key. And the TOE classifies pathophysiology, improves the steering, and improves procedural success. This is especially true also in the annuloplasty, which I show you in the second part. This is a very short part because it's not as prevalent altogether. There are about 200 procedures now with this procedure. It's also venous puncture, also transeptal puncture, and also a very similar system than the mitral clip. The difference is that we deploy a band with a direct annuloplasty like a surgeon, but we're not using sutures, we're using little screws to fixate the band, and then we use a screwdriver in order to cinch and to reduce the size of the mitral annulus. And these steps are given here. I have a patient for you with a huge 100 cc per meter square atrium. This is a huge atrium. It's more than 8 centimeters long, and you see very large volume. You can see a severe regurgitation down back into the right pulmonary veins, and you see the aspect of the valve, which is a functional disease, also given by TOE in this case. Where we start is that we also do a transeptal puncture. I've given you a CT analysis, and it's the same steps. Short axis view, bicable view, which give these 2 planes, and then we do also the height, which is now the 4-chamber view down to the valve. And also in these cases, we need about 3.5 centimeter distance to the valve, and this is CT pre-adjusted. So first, 3-dimensionally, as you will see later by Hani, the septal puncture, we go down with a delivery sheath, we screw in next to the left circumflex coronary artery, we screw in screws along the mitral annulus. You see these in X-plane here. We're near the left atrium, left atrial appendage. Here's the circumflex artery and the beginning of the coronary sinus, and here's the hinge point, as you see. We're on the hinge point on the leaflet with the catheter. We have to move in our landing zone between the vessel, the coronary vessel, and the leaflet. And when we're there, we reach a stable position, and we now begin to screw in the band from the beginning to the end. This is an image from our hybrid OR. By doing this, we use a very brand new situation, which is FlexiSlice or MPR, where we can nicely control the catheter during the intervention, 3-dimensional in all views. And the only picture that's taking live is a 3D data set here that produces all these 2D views. A very modern technique in FlexiSlice or MPR. And we then screw the band all the way down. You see this here with a very high quality. The band is now complete along the posterior ring, is cinched. This is baseline, no band. The band pre-cinching, the screwdriver is in, and here you see that we reduced the mitral annulus directly on the beating heart, and the result is seen here. You see the band here percutaneously delivered, no stenosis. with a very low mean gradient, as you will see later, no regurgitation afterwards, just a trace. And you see that percutaneous direct analplasty is now feasible. 3D echo and fluoro allow also for direct virtual control, and imaging guiding control of the position and angulation is done with flexi slides or MPR with modern scanners. Changing effect and gradients can be controlled directly. So we now continue with Hani Mahmoud with the second part of this webinar. Hani, please.
Thank you so much, Dr. Goldberg-Deliven, for this very elegant and comprehensive at the same time, although the time was very short to cover everything. But as we know, the time is short, we can just take one question from the audience. One question is asking, is there a risk of dislocation of the clip or embolization? If so, what is the treatment? And the other one is, what are the potential peri-procedural complications of TOE? And just we have 1 or 2 minutes for the answer.
Okay, yeah, I'll keep it short. So the first question, there is a certain detachment rate. There are 44,000 procedures done. And to my knowledge, the total embolization rate is less than 3 cases. There is a so-called partial detachment, which has been, when all users have been more unexperienced, has been as high as 6 to 7%. Nowadays, partial detachment, this means the clip is only attached to one leaflet and detaches from the second leaflet. This nowadays happens less than 1%, but it's still possible. And this is especially true if the leaflets are very weak or very short, or if the examiner has bad images to control the grasping of the leaflets. So in modern times, this is a rare complication. You can treat this with a second clip, and you can also prevent this with a second clip, because the second clip takes away the pulling force out of the clip for the leaflets. So to use or to readily employ 2 clips instead of 1, if you have enough space, is one very easy component to prevent partial leaflet detachment. Total leaflet detachment or embolization is, compared to LAA closure, an extremely rare situation with less than 0.1 promille of the procedure. So very, very rare, almost none. The second thing, complications of the TOE during the procedure, this is also extremely rare. As you may have seen, we normally only employ transesophageal views, very little change if you use 3-dimensional echo between transgastric and transesophageal views. The main thing here is patients with portal hypertension, patients that have varicosis of the lower esophagus, or where you pull and push the probe in a banded situation. I think those are the most prevalent possible complication situations, because, of course, these patients are anticoagulated during the procedure, but we had no single case of a complication of bleeding in the esophagus in our more than 1,000 procedures with the TOE. So I think this is also very, very rare. But you have to make sure that your TOE system is straight when you pull back, get into the ventricle, or pull it out there. I hope I was fast enough.
Yeah, thank you so much. I'm going to make it very quickly in order to cover as much as I can of my presentation. My first slide, or my first part of my presentation, will be addressing the role of 2D, 3D TE during TAVI procedure. So I have nothing to disclose. TAVI has dependently, or the TAVI is dependent too much on the echocardiography, although some centers are using now fluoroscopy only to guide the TAVI. But we believe that, especially if those who are in their initial experience with the TAVI program, they have to make it safe and depend on the echocardiography peri-procedure. Echocardiography is involved in patient selection, choice of procedural access, prosthetic choice and sizing, procedural guidance, and detection of early and late complications. A patient like that with a bicuspid aortic valve, as you can see, has a risk of paravalvular regurgitation if we implanted here a TAVI. That is because the elliptical shape of the orifice creates holes on either side of the prosthesis that makes some room for paravalvular regurgitation. A second point is the risk of vascular complications, as those patients with bicuspid aortic valve has really abnormal nature of the aortic root wall. That's why they have a lower threshold of surgery if they have aortic root dilatation. A second category of patients, those who have a significant bulge of the basal septum that causes a risk of balloon migration during simple ballooning, and most importantly during prosthesis deployment, that can cause improper positioning of the prosthesis if it is balloon expandable valve. The procedural axis, a patient with a very clean aortic wall, such as this patient in the long axis view and the short axis as well, this is a very clean descending aortic wall, might be a good candidate for transfemoral approach. On the other hand, if you have a patient with a heavily atheromatous aortic wall, such as this patient, especially if he has something like that, a very fragile atheromatous plaque attached with a small pedicle to the descending aortic wall, just waiting for anything to push it in order to emboli distally, is not a good candidate for transfemoral approach. This is another patient with an arrow-like, very big atheromatous plaque in the descending thoracic aorta, just waiting for anything, for any catheter to push it in order to emboli distally. Such patients are not a good candidate for transfemoral approach. Prosthetic sizing and choice, and this is very important, a very crucial step in procedural success and safety, because undersizing of the prosthesis can cause device migration, significant paravalvular aortic regurgitation, and prosthesis mismatch. And oversizing can cause complications related to the vascular axis, and sometimes it will be difficult to pass and cross the native prosthesis. Sometimes also the very overestimated annulus can cause the overestimation of the prosthetic size. That will cause the prosthetic leaflets to lose its native shape, or it will not be fully expanded, fully open. That will cause some wrinkling inside the prosthesis itself, causing central regurgitation. This image is very important and very illustrative from the guidelines paper, showing the anatomy of the aortic root. We all know that the aortic root, starting from the annulus down to the sinotubular junction, above which is the ascending aorta, below which is the LVOT. We have four imaginary rings here. We have the imaginary ring attaching the basal part of the leaflets, and this is the one that we are interested in during measurement of the aortic annulus for TAVI. And the other one that discriminates between the LVOT and the aortic wall and the crown-like ring of the sinuses and the sinotubular junction. If you notice here, the leaflets are pocket-like with its basal attachment exactly at the lower down at the annulus that we are interested in, and there is another attachment higher up at the sinotubular junction. That means if you really need to measure the maximum dimension of the annulus, you need to cut at one base, and on the other side you have to cut at the commissure. The base is lower down and the commissure point at higher up. That means if you are using the 2D TEE, if you saw two symmetrical bases like that, you should know that you are not cutting the maximum dimension of the annulus, you are just cutting tangentially like that, base to base. But if you need really to cut the maximum dimension of the annulus, you need to cut at one base like that, which is usually the right coronary cusp, which is anterior, and the commissural point between the other two cusps. And here you go to the opposite wall, don't go for the commissural point at the sinotubular junction. This is the true annulus maximum dimension if you are using 2D TEE. If you are using 3D TEE, your mission is much easier. Starting from this view, you can acquire a full volume. That was a full volume over 4 beats, and put this in the MPR mode, multiplanar reformatting mode, and align your lines exactly at the annulus level that you are interested in, and you will get a very clear view of the short axis on-touch view of the aortic valve annulus. If you notice here, it is not circular at all. It is a bit oval, and this is very common in most of our patients. The annulus is really not circular in many of our patients. That's why underestimation is happening if you are only depending on the anteroposterior dimension. But by this, you can avoid this underestimation. You can measure the perimeter or maximum or minimum dimension, and also the distance between the annulus to the left main can be easily measured by 3D CEE. And that was proved in many papers that 3D CEE is advised if you do not have a clear or a good CT data, and it can also be used as a predictor for paravalvular regurgitation. Procedural guidance. It can aid in baseline images and gradients, aid balloon positioning during valvuloplasty, detect post-valvuloplasty aortic regurgitation, aid prosthesis positioning during implantation, confirm prosthesis function immediately post-implantation, and detect complications. Starting from this view, the long axis view, which is the most common view used during TAVI, you can appreciate the annulus and the sinuses and sinitubular junction. We know that if the sinuses of valsalva is obliterated, defined by the difference between the sinus of valsalva diameter and the sinitubular junction, if it is less than 5 millimeters, that carries a higher risk for coronary occlusion. Also, the short axis view is very helpful because it gives you an idea about the calcium distribution and the nearby calcium lumps in relation to the left main ostium. We know that the uneven distribution of calcium carries a higher risk of asymmetrical expansion of the prosthesis with paravalvular regurgitation.
Yes, I'm still here. Yes. Yes. Sorry. Okay. Okay. So what we see here is the wiring situation. It's a transapical procedure where we have a sheath access where the apex, as you can nicely see, we can control the wire, which is often difficult in fluoroscopy alone, that it passes correctly over the aortic valve. And as we see in the next slides, we have the possibility here to then see the sheath across the valve and control during the procedure the balloon, as we see in the next slide. Here you see the balloon which goes across the mitral, the aortic valve, and the balloon can then be expanded under control of echo and of fluoroscopy. As we see in this balloon inflation situation, you can also correct the balloon for its position to the septal bulge here nicely and control that you also reach the leaflet tips. Balloon is now being inflated. There is a chance of balloon migration, which will normally be prevented during rapid pacing. There are also tailored balloons that you can use without rapid pacing, which will also prevent a migration of the balloon during the procedure. Also in these cases, you can use and employ three-dimensional echocardiography, where you have a very nice chance to control also the correct position of the stiff wire, which should not entangle the papillary muscle or the cord. So this is also a possible potential risk of these procedures. We now nicely see a balloon expandable valve where you can also control the position of the stent bases here in the valve area of the aortic valve. And this valve...
Sorry for the disconnection. I'm very sorry for that.
No problem.
I came back.
Take over. I just continued for you a short moment. Please, honey, take over.
Yeah, thank you so much. I'm sorry for that. We have said before that in order to just see the previous slide, that was the positioning of the prosthesis, as our colleague illustrated. That positioning previously was, at the beginning of the experience, was said to be 2 to 4 millimeters below the annulus for the Edwards-Sapien and 5 to 10 millimeters below the annulus for the core valve. But now with the increased experience and with the development of the manufacturing of the new prosthesis, now we agreed for the Edwards-Sapien about 50-50 relation to the annulus. So 50 above the annulus and 50 below the annulus. Why positioning is very important? Because too low implantation can cause migration of the prosthesis itself. It might be difficult to stabilize it, and also the native cusps can overhinge above the prosthesis, causing obstruction to the outflow. On the other hand, too high implantation can cause migration up to the aorta. It may obstruct the coronary ostia, and it can cause also significant paravalvular regurgitation. During rapid pacing, to avoid premature capture and migration of the balloon, and then for the balloon expandable valves, like in this case, full expansion of the valve, full deployment, and the rapid pacing, and at that moment, everybody will look at you and ask you to assess the prosthesis. Starting from the long axis view, you can put color here that will give you an idea about if there is any central regurgitation or any paravalvular regurgitation from below the stent. If you might notice here, there is mild paravalvular regurgitation here, and also the mitral regurgitation that might increase if some complications happen. The short axis view is very helpful in order to make sure that there is equal and symmetrical deployment of the stent and also the motion of the three prosthetic cusps. There is something called wire-induced regurgitation. Sometimes the wire will push and impinge on one of the cusps and keep it open. In that case, you will have a very significant central regurgitation. If you notice that, just some motion of the wire might put the wire in one of the commissures, and in that case, the regurgitation will disappear. And if you are really sure, you can withdraw the wire, pull out the wire, and the regurgitation disappear. Like in that case, this is the same patient in the previous slide after taking the wire out. Prosthetic regurgitation. This is one of the most common complications, and one of the complications that was shown to have increased risk of MACE after the TAVI. Severe aortic regurgitation can occur as a consequence of incomplete expansion, incorrect positioning of the device, restricted cusp motion, or inappropriate prosthetic size. As we said before, the undersized prosthesis is expected to have a paravalvular aortic regurgitation, but an oversized prosthesis is expected to have a central regurgitation due to the wrinkled leaflets. This illustration is showing different types of regurgitation. Central one from inside, especially in oversized prosthesis, and this is treated by another balloon expansion. Paravalvular one is that one is treated by a valve-in-valve. That one is treated, the paravalvular regurg is treated by balloon expansion, another balloon expansion, and this increases the risk of strokes, as we all know. And supraskirtal, especially if it is implanted too low, and it is more frequently encountered if they put the Edwards-Savion valve in a mitral position. In our experience, the transgastric view is a very good view to detect, not to quantify at the beginning, to detect paravalvular regurgitation. Like in this patient, you can notice from below the stent, here you can see two jets of paravalvular regurgitation, but centrally there is no regurg. This is a zoomed view for the same patient. You can notice here the two jets. This is a deep transgastric view. You can see the jet coming nearby the septum here, paravalvular regurgitation. There are a lot of methods to quantify the paravalvular regurg after TAVI. Some of them are the conventional methods to quantify native aortic regurgitation, and some of them are related to the prosthesis. The most practical one, in my opinion, is the circumferential extent of the paravalvular regurg. They said below 10% of the circumference is mild, from 10 to 29% is moderate, more than or equal to 30% is severe. Let's see some cases. We said 30%, so 1/4 of the circumference is 25%, so more than 1/4 can be considered severe. Here it is less than 1/4, about 20% or 25%. That means this patient has moderate paravalvular regurgitation. This patient also has more than one jet, but if you add them up, you can also say this patient has only moderate paravalvular regurgitation. This patient has definitely mild paravalvular regurgitation, and this patient has no paravalvular regurgitation. Mitral regurgitation, this can happen due to two things. Either too long implantation of the prosthesis. If you implanted the prosthesis lower down, it can impinge on the anterior mitral leaflet and cause the leaflet it will not function properly and cause mitral regurgitation significant. Or if the patient has transapical approach of TAVI, this big sheath can disrupt the subvalvular apparatus and causing severe mitral regurgitation. And this happened with this particular patient. After the first ballooning, look to what happened to the mitral valve, very significant increase in mitral regurgitation, and that patient ended up with some decrease in the mitral regurgitation after implantation, and later on it was improved. So in conclusion, for TAVI, TAVI or echocardiography is deeply involved in the patient selection, choice of procedural access, prosthetic choice and sizing, procedural guidance at detection of complications. Let's move very fast to other point, which is the imaging of the interatrial septum. This anatomical illustration is showing the interatrial septum from the right atrial side. This is the superior vena cava, inferior vena cava, aorta. Here is anteriorly, and here is the posterior part of the septum, fossa, and here's the coronary sinus. So they removed the right atrial wall, and now we are looking to the interatrial septum from the right atrial side. If you are using 2D TEE during septal puncture, you have two basic views to start with. You have the bicable view, which will show you the superior inferior vena cava, and you have the short axis base view, which will show you the aortic valve anteriorly and the posterior part of the septum. In any procedure that involves septal puncture, you have to stay away from the aortic valve to avoid the complication of puncturing the aortic root. So you have to be in the posterior part of the septum. On the other hand, superior or inferior, that depends on the procedural type. Like in left atrial appendage closure, you need to be inferior, and mitral crib, you need to be superior. If you are using 3D TEE, here there is another method that will make it easier for you. Rattle maneuver. Rattle stands for rotate anti-clockwise, tilt left for 90 degrees. Starting from the bicable view, activate the 3D zoom capability of the machine, acquire the full length of the septum, the vena cava, both ostia, and part of the aorta and the posterior part of the septum, and acquire that. It will give you a volume with the same orientation of the baseline image. Superior vena cava is to the right, superior vena cava is still to the right. And rotate anti-clockwise, RA, rotate anti, put the superior vena cava upwards, and then tilt left to look from the right side of the septum, and you will have an anatomically oriented view of the interatrial septum from the right atrial side. This is how we do it in real life. The left atrium, right atrium, superior vena cava, inferior vena cava, then activate the 3D zoom. It will give you two planes. Put your lines exactly at the ostia. Superior vena cava is here, rotate anti, RA, then tilt left, TLE. This brown color is the blood intensity. So you decrease down the gain, you will have a very clear view of the interatrial septum from the right atrial side. Some backward tilting, you will see the superior vena cava. Some forward tilting, you will see the IVC, eustachian valve, and coronary sinus. So this is what the 2D will give you, and this is what the 3D will give you. Using that during septal puncture is very easy. This is the catheter coming from the inferior vena cava towards the superior vena cava, and this is the fossa. So the interventionist doesn't need me to tell him where he should go. He knows his way. This is the equivalent view by 2D TEE. And this is how the interventionist will pull down the catheter and the needle from the superior vena cava towards the fossa. As you can see, it's going without even looking to the fluoroscopy. This is another example where the catheter was pointing anteriorly towards the aorta, and he clockwise this catheter to push on the fossa, as you can see. If you do not appreciate the tenting, you can tilt this volume to the left and look to the septum from the side, and you can appreciate very easily the tenting. This is another example of the catheter here impinging on the septum, and this is the aorta, so you can clearly see the tissues and the catheter at the same time without fluoroscopy. And we could prove that it really reduces fluoroscopy exposure. So assessment of the left atrial appendage quickly, if you are using 2D TEE, you have to acquire different views for the appendage in different angles. From the 0 degrees, you can freeze and then measure the ostium 1.5 or 2 centimeters from the tip of the comedine ridge to opposite to the ostium of the circumflex, and this is the ostium, and then the usable length from this point to the tip of the appendage. This is if you are planning for appendage closure. From the 45 degrees, you do the same, and from the 90 degrees also, you do the same, and then from 135 degrees. Why is that? Why do I have to get the appendage in many degrees? The answer is here. If you look to the 3D volume of the appendage, you can notice that the ostium of the appendage is oval. It is not circle. So one dimension will not be a good representative for the ostium of the appendage. This is the ostium here of the appendage on first view, and this is the comedine ridge, left upper pulmonary vein, and this commissure is the anterolateral commissure of the mitral valve, and this is the aortic valve. Put this single volume in the MPR mode, and you can put your lines, whatever you want, exactly at the ostium of the appendage, and you can have a very clear view of the ostium. If you notice here, it is dynamic. It is not fixed. It's changing over time, and this is the good advantage for the 3D TE. You can freeze on the maximum dimension, or the frame that shows you the maximum dimension, and measure it, and measure the usable length, and screen how many lobes this appendage has, and just tell the interventionist, this is the ostium, choose your device. And that was very well correlated with the CT measurement. The last thing, percutaneous balloon valvuloplasty, and that was shown to be very well monitored by 2D or better by 3D TE. This is an example of one of our patients. The left atrial view, mitral valve is down, left atrial appendage is here. The catheter is coming from the right side, puncturing the septum. Balloon is here, inside the mitral valve now, and we can monitor everything without even fluoroscopy and ballooning as well. This is ballooning of the valve on direct vision, and also you can use it to compare the results. That was the patient before with some calcium lump here at the medial commissure, and there is no calcium at the lateral commissure. That's why you can notice after ballooning that the medial commissure didn't open too much because of this lump of calcium, but it really opened on the lateral commissure because there was no calcium. So it helps a lot in monitoring the procedures, and it can make it safer and faster. And here I can end, and thank you so much.
Votre conférence a été rallongée de 25 minutes.
Thank you very much, Hani. I hope we're still online. I would like to go now to the latest questions, and we try to have about 2 minutes for questions. We get very good feedback from Russia, from the UK, from Poland, from Germany, Serbia, Ukraine, Macedonia. So a lot of people thanking Leipzig. We have UK here saying very interesting webinar. So Hani, very, very good. We have some specific questions also. And one of the questions is, where are TAVR procedures done in Egypt? And what is the number of cases per year that is being performed in Egypt? I may preclude already that in Germany, about 18,000 TAVR procedures now are being done per year, and this outperforms surgery in Germany at the moment. What about Egypt? How far are we there? Honey.
No, it is shameful a little bit to speak about TAVI in Egypt if we're comparing this to the numbers in Germany. But we can say that many hospitals now started recently because of the financial problems doing the TAVI, because as we said at the beginning, it is not covered by the government. So patients who can afford it are those who can get it. But I can say it is done regularly in some hospitals that started the program. They are being done almost every week. In my hospital, Aswan Heart Center, we are doing that very regularly. There is no week without 1 or 2 cases of TAVI, and this is a good rate for Egypt.
Okay. Another question is, how many echo procedures do we need to gain competence in TAVR procedures? Of course, it's very important. You've shown exclusively echo. Of course, we also use fluoroscopy and CT. We have to make this clear during these procedures, but you showed nicely how we can also guide by echo. How to gain competence, and this is an important question. Diagnostic echo is not all that you need in interventional echocardiography. And my feeling is that we need a specific education into the interventional echocardiographer and the interventional imager. What is your experience? How many procedures should you have guided or seen in order to become competent in performing echo during TVR procedures, Hani?
This is a very interesting question. I think that the key issue of that is to have a hard team. It is not one-man show, and I agree with you too much that CT fluoroscopy is a cornerstone as well. But because I'm an echocardiographer, I've shown only echo images. But for me, attending at least 10 cases supervised and seeing, before that, seeing about 5 to 10 cases, that you have to encounter some complications as well in order to know how to detect them and how to conduct the message to the interventionist and the anesthetist as well. This is very important. So about 15 cases seen and supervised. After that, I feel that we can do TAVI with collaboration with the interventionist who has to be has a good command of the echocardiography as well in order to understand what you are saying.
I could not more than agree with you, Hani Mahmoud, and I would now like to conclude, I think, and also the user comments are coming in by the second. We have a lot of viewers from Egypt, your country, from Georgia, Germany, Sweden, Stockholm, from Italy even, from Serbia, Macedonia, France, Russia, again, Saudi Arabia, the Canary Islands, Bosnia-Herzegovina, the Madeira Islands, Portugal, Romania. So a very, very broad spectrum. And I thank every one of the viewers very much that they found this webinar interesting. I would like to conclude. We have seen 5 major topics of interventional use of TOE during procedures. We started with the mitral space, showing leaflet-to-leaflet therapy with the MitraClip, the most prevalent option in interventional procedures for the mitral regurgitation. We have then seen the annuloplasty, which is a quite new procedure, having less than 200 implants worldwide, but also using TOE very importantly during the procedure in the cath lab. You cannot do it without echo in the future there. We have then moved over to a very important procedure, which is the TVR procedure that you, Hani, covered very elegantly. And we've seen that we can do a lot of procedural guidance and also complication assessment and PVL assessment during the procedure. You then switched to the transeptal puncture that I only shortly mentioned in a very elegant 3D way to steer this procedure. We then looked in a short way down to the LAA and for the stenosis into balloon valvoplasty. I think we all have seen very elegantly the use of 3-dimensional and 2-dimensional echo in all these procedures. And I would now like to conclude and thank everybody of the viewers from all over Europe, Russia, and even the islands out next to Africa. And I hope to see you again on one of the further hit EACVI webinars. Thank you very much. This was Hani Mahmoud from Egypt, Stefan von Bardeleben from Mainz, Germany. Thank you very much.